एक्सप्रेशन भी दिखेगा
सर ये पेन ड्राइव पे लगा के ना
मास्क पहन के करना है या बिना
जैसे
ज़रूरत
आपको
नहीं
चाहिए।
है बाकी लोग कैसे भी है
सर कोई मार्क्स से भी कर देता, कोई वैसे ही कर देता है।
वो लोग भी देख सकते हैं
हाँ जी।
स्टूडेंट्स
आप चालू है सर।
चालू करो आप चालू कर सकते और न्यूरो के लिए वेट नहीं करो
नहीं कर मैं आप अपना तो चालू कर सकते।
Okay, good afternoon everybody. This will be a class on stroke rehabilitation. So we'll see in this series of slides about what is stroke rehabilitation, the basic issues, that is when exactly the stroke rehabilitation is to be instituted, how much of rehab is proper rehab, and whether at all if there is any efficacy to the stroke rehab, a few points on that, and then we'll go into the specific issues, that is the major components of the stroke rehabilitation. So what is rehabilitation? Rehabilitation is a combined and coordinated use of several measures, and these measures include medical, which includes both physical and psychological, and also other non-medical measures like social, educational and vocational, etc. And these measures have to be given in a combined and coordinated manner in order to train or retrain the individual who has been afflicted with any disease. Here in this case, let's assume that he has stroke. Then we have to find out what are the deficits that he has, and we use these measures to retrain the individual so that he achieves his highest functional ability, so that he becomes he can contribute positively to the society. So that is the definition of rehabilitation. And I hope you're all aware about the ICF model of stroke. And in the ICF model we see broadly like what is the structure or the function that is affected, and because of this structure and affection that has been affected, what are the activities that become limited, and ultimately what are the participation in which the person with the disease is not able to participate, and other factors which contribute or influence these things, which includes the environmental factors and personal factors. For example, taking the case of a stroke, herein we know that the brain is one that is involved, and because of which several function of the body is limited. And taking into example, like if the muscle power is affected, then the person is not able to perform his activities of daily living, which will include simple things that we take for granted for every day, like taking a bath, dressing up, eating, and walking, etc. Or all these activities are affected, and as a result of this affliction he is not able to participate in the socially, which means like he is not, if he is a student he is not able to go to the college, or if he is an adult he is not able to go for a gainful employment, and thus it affects a person from participating actively in a social life. And there are also several factors which affect it, like environmental factors. For example, in the environmental is the availability of health professionals who can deal with such persons with disability. So are these available? If it is available, then probably the person can be rehabilitated and can make him gainfully employed, for example. And also there are several factors, like the person himself has to be ready to adapt, to be psychologically and be ready to adapt to the needs and to the special needs as per the situation demands. So just like any other concept of assessment, rehabilitation, so basically we have to do initially a baseline assessment. The baseline assessment is not very specific for rehabilitation, it's just like any other assessment for any other systems, that is the central nervous system. So you look at the tone of the muscle, whether it is high tone like spasticity is present, or whether the range of motion is adequate or inadequate, whether there is a presence or absence of contractures, and what is the muscle power. And apart from these assessments, do not function to assess the functional impact, that is whether the person is able to walk. For example, a gait assessment will be quite useful in a person affected with stroke in order to find out what are the limitations and thereby what interventions need to be given. And after this baseline assessment is done, you have make a list of the problem areas, and then you set goals in order to find out wherein you have to intervene. So you have to take a careful plan based upon this assessment, based upon the goals, and the goals not only based upon the impairments but also take into consideration the patient, what are its needs for, as per his needs. And then you plan a systematic intervention, and thus it has to be individualized, not exactly customized. It has to be customized to the person as per the need of the patient. When to start the stroke rehabilitation? Well, as soon as the patient is stable, you can start stroke rehabilitation. That is, once the patient is medically stable. So even in the ICU, some interventions are also to be given, like for example, simple range of motion exercises, positioning in order to prevent contractures, etc. are indicated. But intensive rehabilitation, wherein we expect the patient to come to the gym and participate, those things are avoided till a little bit when the patient becomes medically stable. And too intensive a rehabilitation started too early can also have a detrimental effect. As per this study, we have a study called our trial, which is a very early rehabilitation trial, in which intensive and very high dosage of high dose of rehabilitation was instituted at a very early stage, and it was found in such persons the recovery from stroke was in fact delayed or lesser than expected. So is there a threshold how much of stroke rehabilitation is to be given? Well, exactly, there is no systematic study, but based upon some statistical analysis of some studies, they have found that there does exist a threshold, and below this threshold there is a development of compensatory strategies. And if the threshold is achieved, that is, when I talk about threshold, I am talking about the hours that the person spends in the therapy. So for example, this is for stroke rehab, this is considered as 3 hours. 3 hours of rehabilitation is quite important in stroke impaired individuals. This is important in order to help the networks which are haphazard because of the thrown haywire because of the stroke to become organized. So that is what rehabilitation is all about. Is there any evidence for this? Yes, there is definitely evidence based on this rat model. This was the rat model in which cut section was taken, and it was found there was excellent improvement in the motor reorganization that is occurring in persons with stroke, in rats with stroke which are doing hand forelimb activities. That is, so cortical representation of the forelimb is improved when such activities are promoted in the rats. So what are the factors that affect motor recovery in stroke? There are several factors, but the most important 2 factors are the stroke severity and the age. That is, more severe the stroke, the recovery is going to be less, and the younger the age, the prognosis is is very good. So these are the 2 important factors. And when I talk about recovery, what I mean is there are 2 types of recovery which we have to understand at this stage. One is the neurological recovery, and other is the functional recovery. So neurological recovery is recovery of impairment. That is, we talk, what is impairment? Impairment is a loss of normal anatomical function or the anatomical part or limb, etc. So there is a normal recovery of this function, and the person is able to perform the range of motion or the movement pattern in the same way as the premorbid condition. So this can be assessed by using complex kinetics like 3D kinematics, that which is used in gait assessment, etc., wherein sensors are placed in different parts of the limb and the movement is tracked. And if the movement is same as before the impairment, then that is the stroke, then it can be told that the neurological recovery has occurred. And this neurological recovery usually occurs within the first few months, that is within 1 to 3 months. And again, this recovery, as I stated before, depends upon the severity of the stroke and depends upon the age. Younger the age, the neurological recovery is going to be very good, and lesser the severity of the stroke, the recovery is going to be good. So is the recovery, neurological recovery, equal to functional recovery? Well, not exactly, because sometimes even though the motor power has recovered, the combined complex coordinated movements can still be affected because of other because of impairments in other places in the brain. Like for example, the person may have some sensory impairment, or there may be some cognitive impairment, or there may be apraxia, etc. Conditions like that can prevent the patient from performing a coordinate activity in spite of the presence of motor power. So here comes the functional recovery. The functional recovery is a little different from totally different from the neurological recovery, where here when I talk about functional recovery, I'm talking about recovery of the tasks through compensatory movements. That is the normal, instead of the normal movement, the patient is compensating for that. And how this can be assessed by different functional outcome measures like Barthel index, etc. And this functional recovery occurs a little later after the neurological recovery, and it can occur up to 3 years. So this is the time period wherein, that is from 6 months to 3 years, as early as possible, and at least till 3 years we had to give intense rehabilitation for the successful functional recovery to occur. If not, then there may be some complications that can arise because of improper rehabilitation. And what are the factors that can affect this functional recovery? There are several factors. That is motivation. The patient has to be motivated to participate in the rehab program. We can only advise, we can only take the horse to the pond, but we cannot make it drink. So it is the motivation that makes the patient to put time and effort to relearn the process and to help in the cortical reorganization. It is the ability to learn. The support, the family and the social support must be positive in order to help aid the functional recovery, and more important, the availability and the presence of qualified and quality therapy is important for the functional recovery to happen. So to revise a little bit, so we have seen the stroke rehabilitation. We know rehabilitation is a combined and coordinated effort of several measures, which can be physical, medical, that is physical, which can include medical, surgical or psychological, and apart from medical, there are non-medical measures like social, vocational, educational. So the combined measures which is given in a coordinated manner in order to retrain the individual to maximize his function. So that is rehab. So we are going into stroke rehab. We have seen when it has to be started, it has to be started as early as possible. It starts right at the ICU, but it should not be too intense because that can be detrimental. It threshold like 3 hours of therapy as soon as the patient is as medically stable and he has the enough functional capacity. There is the aerobic capacity to participate continuously for 3 hours. It will not be continuously for 3 hours. Okay, 3 hours can even be broken down. For example, morning he can spend some session in one type of therapy, and in the afternoon or in the late in the evening he can spend another 1 hour in another type of therapy. So overall it has to be for 3 hours over a period of weeks and months so that intense rehabilitation can be completed. So that is the basics of stroke rehab. Now let us go into the major components of stroke rehab. So what are these components that we'll see here? So what are the impairments? So it can be either sensory or motor impairments. So we will see how to rehab this, how rehab can improve, or how it can make the patient cope up with these impairments. Let us go into that, and then we shall also see how to prevent some complications, medical complications which can be prevented, and finally a few basic issues about going back to work, about driving and sexual activity, etc. So first, the rehab component is the sensorimotor impairment activities. Now there is a long list of motor activities that is going to be affected. As I've shown this slide earlier also, you saw that the brain is affected. So when the brain is affected, it controls everything, each and everything. You have cognition, you have vision, you have hearing, you have speech, you have motor power, muscle power, tone. So all this function, if it is going to be affected, then there is a long list of activities that is going to be affected, which could be anything that is simple like taking a bath or dressing can be affected, or it could be something more specific like ability to speak, or in fact even more specific like ability to comprehend. So depending upon the individual impairment, the intervention has to be planned. And going on to the most common impairments, it's too difficult to cover all the impairments, but let us go into a little bit into the most common impairments that we deal more commonly in our stroke rehab unit. This could be like dysphagia, and we will not go into the detail of non-motor impairment, in which we will be concentrating on. But what is important in rehabilitation is that it is not a piecemeal intervention, it is a comprehensive intervention. So unless the intervention is given more comprehensively, the outcome of the rehabilitation is not going to be good. And that is why I am going to cover a little bit of topics which are non-physical topics, like why dysphagia is important. Dysphagia, definitely it's important. It's difficulty in swallowing. Why it is important? Because it can lead to pneumonia, but in the long run it can lead to malnutrition, dehydration. So in the early stages, usually a nasogastric feeding tube is given, And if this has to be prolonged for more than 3 weeks, then percutaneous gastrostomy tubes is given. And before starting oral feeds, it is important to start some evaluation to see whether the swallowing has come back, the swallowing function has come back, has recovered. So it could be either a simple bedside evaluation, or it could be a more comprehensive instrumental evaluation like fiber optic endoscopy, or it could be video fluoroscopy, etc. So when it comes to rehab, it is mostly the speech and language therapists. They are the special group of people called speech and language pathologists, which work under the PMR person, that is in rehabilitation unit. They take care of basically the speech and the swallowing aspect, and they intervene based depending upon the need of the patient. They teach the person some compensatory strategies. A very simple strategy like sitting upright while eating, that could be a simple thing, or appropriate positioning of the neck and the face. That could also be used in order to prevent the aspiration. So it is too difficult to go into the details, but these are the interventions that are possible, like positioning of the person, positioning of the face and the neck, and several swallowing exercises can also be done, and simple strategies like modifying the diet can also prevent unnecessary aspirations. And then there is the cognitive impairment, which usually the psychologists take care of. And a brief overview is that none of the drug has been shown to improve any cognitive impairment, but what is most important is to provide an enriching environment. An environment which is like substandard, which is not stimulating, then it is not going to be cognitively enriching. So when you provide what do you mean by providing an enriching environment? It could be anything that the person with stroke is interested in. So for example, it could be placing a TV and playing his favorite movies. It could be like keeping an iPad and asking him to use it to communicate with people outside, to interact with people. Or it could be just to read a news, or listen to some lectures, or if he is interested. So it depends upon providing an enriching environment, providing just dates and calendars, newspapers, internet connection, computer, iPads, and things like that can be cognitively stimulating to the person. So that is more than sufficient. And music, whether it has a role, we still do not know, but there is no harm in trying some therapies like music. But definitely exercise has some role in cognitive decline especially, and cognitive impairment. So aerobic exercise, here by exercises is not simple range of motion exercises, but talking about aerobic exercises. And what are aerobic exercises? These are like walking, standing, cycling, etc. If the patient is able to do, then they will be very good in improving the cognitive impairment. If the patient still does not develop any improvement, that is no neurological recovery, then we are talk about what is functional recovery. So how can we functionally intervene here? We have to provide it with some compensatory strategies. By compensatory strategies, it could be like when we read, we prepare notes. So that is a strategy in order to remember. So making notes, taking reminders, keeping alarm in your clock, keeping alarm in order to remind the patient so that he can take his tablets. So it could be like simple strategies in order to cope up with the cognitive impairment. Then there is this problem of neglect. Neglect is defined as a failure to respond, or failure to respond to a stimuli which is presented in one particular side, which is contralateral to the stroke lesion side. For example, if you see this in this slide, there is a picture. There are 4 pictures here. This is a painting by an artist, and this was through the phase of the stroke recovery. And in the initial phase, he had neglect, and as it is known, most of this neglect improves in the first few months. And as the painting also is showing, we can see how much he is neglecting the left side in the initial picture, and gradually this improves. And look at the final picture, which looks amazingly normal. So this is what neglect is about. It is failure to respond to an external stimuli, and it is contralateral, whether it can be detected by simple screening tool like a line bisection test, in which several lines placed in different places of the A4 paper is shown to the patient, and is asked to bisect the center of the line. So if he fails to bisect it, if by more than 6 millimeter, then it shows that he is having neglect. But of course, the screening tool can still miss some of the neglect, that is false positives can still occur. So how do we deal with neglect? There are several strategies. Basically, there are 2 groups of strategies. One is known as a top-down approach. Top-down, again, it means compensatory approach, and other is the bottom approach, wherein you are aiding the neurological recovery. So basically, we are talking about rehab to aid the neurological recovery, and another set of rehab interventions which is a compensative strategy to improve the functional recovery. So for neurological recovery we do what is known as a bottom-up approach, and for the compensative strategy we had different types of thing like visual scanning training. So that is the most common, and wherein you teach the patient to just move around and look to the left side. It's a behavioral modification, or there can be an external stimuli like in this picture. An external stimuli can be placed in the form of a laser or form of any light, or it could be even person sitting on the left side trying to talk to him. So that could be a form of visual feedback or a visual training, which so that the neglect is decreased. And there are some bottom-up approaches wherein you increase the perception of space, which will improve the neurological recovery. So one common approach is the eye patching. For example, you look at this glass, it has a patch, black patch, and if by putting this patch, what you are actually doing is, for example, two patches on the same side, that is the contralateral side, is the left side, for example. So if it is affected, so we keep the patch on the right side so that enough stimuli from the right is decreased, and we increase the stimuli from the left. So what it does is, when the visual stimuli you allow only from the left to enter in, and therefore it goes and activates the contralateral brain, and when it goes and activates the contralateral brain, it may help in the recovery or in the cortical reorganization. For example, there are some simple techniques like limb activation therapy. So what is limb activation? You just have to move the limb. It could be just moving a simple finger also. So you move the finger or the limb, then the signals goes to the contralateral brain and activates the brain, and thereby it can lead to reorganization of the cortex and thereby decreasing the neglect. And here it is movement, so it is limb activation, whereas in the previous, in patch, it was the visual stimuli which you are allowing from the left side to go and activate the brain. So the strategy remains the same. And there are several other strategies. We will not go into the detail. That could be like brain stimulation, that is transcranial brain stimulation, could be current stimulation or transcranial magnetic stimulation. Then there are some vibration techniques, etc. But the most common is limb activation therapy, eye patching, and visual scanning. And there are some communication disorders. Again, the cognition has to be intact for the communication to present. And again, here there is a role, as I said before, of the speech and language therapist, who will assess not only the swallowing function but also communication function, and depending upon the deficit they can give some compensatory strategies, or they can train the person. So far there has been no drug that has been shown to be effective, though some studies have shown drugs like donepezil have been used in improving the communication, but not proven. And the stimulation techniques like transcranial direct stimulation, direct current stimulation, and transcranial magnetic stimulation still in experimental stages. Sometimes you also have to think about training the partner. For example, it's like learning when communicating with a dumb person, you learn the sign language. It's like that. So you learn the sign language, you are able to communicate with the person who is deaf and dumb. So like that, you can train the partner so that he is able to understand the person afflicted with stroke properly. And if that is not possible, then we have some excellent communication devices that could be passive, like communication chart. For example, the patient in the picture, there are some pictorial representations. Suppose a patient wants food, he can point towards a pictorial representation of, it says, I am hungry, or what is the time, what are you doing, how are you doing, I am tired, let me go to sleep, I am having pain, so give me some medication. So you can use these charts for the person to communicate with the partner or with the caregiver. And it could be just a chart, or it could be in the form of an iPad, which even children find it quite useful. For example, in persons with cerebral palsy also, such alternative augmented communication devices are quite often used in order to establish communication. Why? Because communication is very important for success in a social life. So establishing good communication is quite important. So in rehabilitation, that we have seen now some psychological issues like some speech impairment and all those things. Now coming to motor issues, so there are some functions which can impede the rehabilitation intervention, and that could be like increased muscle tone, like spasticity. The presence of spasticity per se does not mean that it has to be treated. For example, a minimal spasticity can even be beneficial. for example, of the quadriceps, spasticity of the quadriceps, it can keep the knee stiff and prevent its buckling while walking. So because even though weakness may be there, the spasticity may be compensating for it, and that it may be useful, and there is no necessity to go and decrease the spasticity. In other persons, the spasticity, if it is copable, that is, for example, there is adductor spasticity, but it is still manageable, it is not affecting the perineal hygiene, I don't have to intervene. But if it is affecting the perineal hygiene, if the spasticity is too high that I'm not able to abduct the thighs and take care of the perineal hygiene, then I have to intervene. So if the spasticity is generalized, that is of the whole limb or of the whole lower limb, then you take medications. But oral medications have their own side effects. For example, we commonly use tizanidine, or we use baclofen. Baclofen can decrease the seizure threshold, or all these things can also affect the cognition. The side effect is they can cause slowness of movements, they can cause sedation. Sedation can impede the person from participating in rehabilitation. So if there are some side effects, it's always better to intervene locally. For example, that depends upon which muscle is affected. For example, here you see there are different muscles that can be targeted. That is, botulinum toxin is the most common used intervention technique for local spasticity of a particular muscle group. For example, if the person is having adduction, which is a common posture, adduction and internal rotation, then we give Botox injection to the particular muscle groups, that is the subscapularis and pectoralis major. So here is the long list of muscle groups and the impairment for which they have to be targeted. For example, the common thumb in palm deformity or the flexed wrist, there is a clenched fist is a common problem. Then you target only the long flexors, that is the flexor digitorum profundus and also the flexor digitorum sublimis, and also the thenar muscles can be used. Thumb in palm deformity, you can target the adductor pollicis, flexor pollicis longus, and the thenar group of the muscles for the clenched fist and the thumb in palm deformity. So you identify the muscle group which is affected, and you put the Botox in that muscle group, relax the muscle. Whether it is beneficial, yes, it is definitely beneficial, but the benefit is limited to 3 to 4 months, or maximum up to 6 months, after which you may have to redo the whole procedure, that is, re-give the Botox injection procedure all over again. And coming then to physical modalities, there are not much physical modalities to take care of spasticity, but it is important to do continue with the range of motion exercises, because spasticity when the muscle is tight can place the muscles, lead to contractures. It could be the contracture of the sarcomere, or it could be contracture of the non-muscle elements, like the soft tissues, that is the tendon, or it could be the joint, soft tissues around the joint. So it is important to continue with the range of motion apart from the intervention techniques like Botox. And there are some other techniques like electrical stimulation and vibration, and also just ice application. But they are mostly adjunctive, not that much beneficial in the long term, but can be used as an adjunctive. And the efficacy, again, just like any other medication, the efficacy is short lasting. As long as for a few hours, it can be useful. These measures can be useful. Then there are other impairments, that is the balance impairment, which should not be neglected. So we can use some scales or during the assessments in order to detect the balance impairment and put them into training. This could be simple training, like simple standing and balancing in one leg and trying to reach out. It could be simple physical therapy training, or could be some specific training of the trunk muscles using some physio balls. Or it could be some programs like yoga and Tai Chi programs are also useful in improving the balance assessment. And sometimes when you have to improve the balance, sometimes all you have to do is give a cane in order to prevent the fall. So don't forget the simple cane whenever the balance and increased frequency of fall is affecting. It can lead to morbid problem like contractures. And there are some improve the balance training. There are some, what you see here is a balance training master. So in which the patient stands inside this device, and there is a visual feedback, as well as the place on the platform on which he stands also moves, and also the environment which is enclosing all around also can move, tilt up and down. So it can, depending upon the need of the person, the amount of the balance effects can be given to the patient in order to compensate for the balance movements, and training can be initiated. And to prevent him from fall, there are some hangers which can loops and hangers attached to the vest in order to prevent him from falling. Training can also be can be done using these devices, but simple strategies like simple balance, standing balance, walking in line, and therapies using the physio balls are also quite effective. More importantly, then coming to mobility. So mobility is quite often the most often, and also what affects the patient. The patient says that he wants to walk, the first thing that he comes to you and says. So to walk, you can improve walking only by walking. There is no other shortcut to it. Those who want to walk learn only by walking. So it has to be task specific, that is, he has to do again and again. It's just like how the child learns to walk. The developmental milestones, think of the developmental milestones of the child. Neck control comes in, then the child sits with support, then sits independently, then the child starts standing with support, then starts walking. Then walking, it's not a single day affair. The child walks, falls down, gets up and walks again. But with repeated activity, an engram is formed in the brain that which can help in building the cortical reorganization. And to help aid in this activity, task-specific training, there is some specific intervention strategies known as circuit class training. Circuit class training is nothing but different stations. For example, in this picture you see there are some 5 to 6 individuals, and each one is performing one activity. So each activity is a station. So in one station we can see this person here is sitting, and what she is actually doing is trying to improve her sitting balance. And this person is actually doing some hand activity. This person is doing some lower limb activity. This person is trying to improve his balance, and this person is performing squats maybe, or ability to stand with the help of the parallel bar by holding on to some railings. So each one is a station, and they perform an activity in each station for a few minutes, say for 5 to 10 minutes, and with the ring of a bell, after 10 minutes, all this patient will shift to one station to the next, and thereby in a group within a 1 hour period. So each person will perform a 10-minute of 6 different stations, performing very different activities which may include both the upper limb and the lower limb, can improve the to make the rehabilitation intervention a little bit more interesting and also at the same time comprehensive. And the patient is able to walk, he has to walk, and to aid him in walking, he can walk in a treadmill or he can walk on the ground, but he is not able to stand at all. Then you have to give body weight support. So what is body weight support? Here is a person who is using a harness to tie to his vest, so that his weight of the body is supported by the system. So it is a body weight supported system through the vest and the harness system. So since he has the ability to stand is impaired, that is standing balance in persons who are not have impaired standing balance, such patients can be given a body weight support, and a therapist can also assist him in order to walk. So this is a body weight support treadmill training, which is quite commonly used in rehab strategies, rehab centers. And it can be either manual, as we have seen before, with the help of body weight support, or it could be a person. If such techniques are not available, then it could be simply 2 persons making the person stand and assisting him and taking for a walk. That could be the simple body weight support in a resource-less environment, for example. And in places where the person is not at all able to stand, we have some advanced techniques like robotic assisted training. Herein, there is not just a body weight support system, but it's also a system is attached to the lower limb. Here you can see the exoskeleton, which is attached to the lower limb, to the thigh and to the leg, and also to the foot, so that it performs a repetitive activity of walking. So this is useful in a person who has very poor lower limb power. So he is neither able to stand and balance himself, and not having motor power which allows for movement of the limbs. In such persons, a robot assisted training may be given. The efficacy of all this is not yet completely proven, but definitely some low quality evidence has definitely been found in, especially in subacute and subchronic or chronic strokes. Rehabilitation robot assisted training has been found to be to some extent useful. So apart from this task specific training, Other forms of basic exercises should not be forgotten. This could be like stretching, it could be strengthening, it could be balance training. So you have to give stretching of or range of motion of the joints. You have to increase the strength of the joints by doing some weight lifting. And again, balance training, as I told before, it could be simple standing balance or walking or using some trainers or some instruments like balance trainers. And also improving the aerobic capacity is also important. Some patients may need some orthosis in order to improve the mobility, and the orthosis very commonly used is the ankle foot orthosis. This is a conventional ankle foot orthosis, and this is a plastic ankle foot orthosis. This is used commonly in stroke. If you see, he will walk with a hemiplegic gait is quite common. Now this hemiplegic gait, why does it occur? It occurs because the dorsiflexors have lost their power, and therefore the foot goes into plantar flexion and there is inadequate clearance. So in order to a compensatory strategy in order to prevent the person from tripping is either he is going to do increased hip and knee flexion to clear the ground, or he will develop a circumduction gait. And these compensatory strategies develop only because we do not give such kind of orthosis at a quite early stage before such compensatory strategies set in. Because once the strategy is set in, even if you give the orthosis, the person, because of the behavioral adjustments, behavioral adaptations, he will still continue to walk with the circumduction gait, and it becomes very difficult to break the behavioral pattern. Of course, it can be broken, but it will require a more intensive training and reinforcement, both verbally or by using mirror feedbacks, etc. So this is a simple ankle foot orthosis which can be used to prevent such scenario of circumduction gait. It could be a plastic made of polypropylene or polyvinyl and with a soft inner lining, and the other is the conventional orthosis. This is a conventional orthosis, whereas this is the polypropylene type of AFO. And another type of AFO is known as the functional orthosis, or also known as the FES. FES stands here for functional electrical stimulation based neural orthosis. This is a functional electrical stimulation system. This is a simple device. Herein you see a cuff, and you can see this person is the programming device, and this is the device which is wrapped around the knee with the stimulator. It provides a stimulation to the common peroneal nerve, and thereby causing the dorsiflexion, and there will be this is the foot switch. So this is the switch which is put inside the shoe. Why this is important? Because this system here will deliver a stimulus which will cause dorsiflexion only when the foot is off, that is heel off. You can see here from this diagram. Here the stimulation is off during this period. So when the foot switch here, which is placed inside the shoe, detects that the heel is off the ground, it sends a signal to the stimulator to start the stimulation, and when the stimulation occurs, there is dorsiflexion of the foot and the ability for the person to do a easy clearance of the ground, that is the ability to do a proper swing phase of the gait cycle. So one is the ability to do walking, and to assist them in walking, as I said before, it could be to assist them with community walking. There could be some devices, simple assistive devices can be used, walking aids, that is, it could be a cane or it could be a walker depending upon the need, or to move around inside the home, some institution of grab bars inside the bathroom is quite important in order to improve the mobility. And for long distance mobility, we can also use some powered wheelchair or some community ambulatory, or inside the home they can in fact use sometimes manual wheelchairs. And this is a single hand driven wheelchair, because in a conventional wheelchair a person has to propel both the wheels, but in a person with stroke who is not able to use the other hand, for example, in this case the left hand is not able to propel, then he holds on to both the rims here and propels it. So that is a simple modification, which is one hand driven wheelchair which can be used by stroke patients. Now so far we have seen the motor intervention strategies for the lower limb. So now we'll come and we'll have a brief look at the motor intervention strategies for the upper limb. even though it is not proper to classify broadly as this, but to remember it, we can see when there is some power present in the upper limb, then we can do, just as I said before, if the person is able to walk, make him walk. So what do you do with the upper limb? Ask him to do all the activities that the upper limb is performing. That is like, it could be dressing up, it could be wearing the socks, it could be wearing a shirt, or performing the particular functional task, and repeat it again and again, so that the functional task is ingrained in the brain. And also there are several intervention strategies like CIMT. We will come to see what it is. It is quite the in-thing phenomenon when it comes to stroke rehab. It is known as constraint-induced movement therapy. And also with the advanced technology, we can also use virtual reality and video gaming. And when the motor power is very less, that is, let's say in the grade of 0, 1, etc., is there any strategy that can be done? Yes, there are some strategies. We'll have a brief look at that. It could be mental practice, it could be mirror therapy, it could be electrical stimulation, and of course robotics can still be used. Just like we use for the lower limb, we can also use, there are robots available for the upper limb in order to do some activities, in order to help relearn the activities. And most important, again, just like a person learns to walk by walking, for the upper limb, again, you ask the person to perform the particular function. It could be like transfer activity, it could be dressing, upper body dressing, or it could be a lower body dressing. The functional tasks have to be done, it has to be task specific. The training has to be task specific, and it has to be repetitive. These two are important. Task specific repetitive training helps improve their cortical reorganization, and also makes it interesting to the person, because just performing a range of motion exercises, just performing the dumbbells, etc., may not be that interesting, because after all, when he goes back from the gym to the home, he has to do these tasks. The stroke person has to be made independent in these tasks. So such training is instituted as early as possible, as soon as the patient is medically stable and has the functional capacity and the aerobic capacity to participate in the gym, in the training program for at least 3 hours over a period of time, over the 24-hour period. Basically, most of these strategies are very simple. That is, it's just like a video game. In a video game, unless it is interesting, you're not going to play. And also in the video game, you increase the goal, make it a little bit interesting by making it a little bit harder than before. If it is too hard, it can be frustrating. If it is too easy, it's going to be boring. That is what the video game is all about. So you build up the game and you increase the difficulty level of the game so that it can keep the person engaged. So it is the same principle for stroke rehab also. If you give him too hard an activity to perform, he is going to get frustrated, he is not going to participate in it. And you make it too easy, it will be boring. So goal setting, that is why when I was introducing the stroke rehab, I had told it is important to assess, find out what is his residual capacity. Based upon this residual capacity and his interest, you set the goal, and the goal has to be in a step ladder fashion so that you're able to achieve and go back to the next goal. It helps you not only to make it interesting, but also it will help you monitor the progress of the patient. So goal setting is quite important, and make it meaningful and interesting. And coming to the next, after the slight deviation, the other activity, when the muscle power a little bit is present here, it's constraint-induced movement therapy. A little bit movement of wrist extension, that is at least 20 degree of wrist extension and 10 degree of active finger extension have to be present for the constraint-induced movement therapy to be started. If such movement is not present, if it is absolutely zero, then absolutely this therapy has absolutely no role. Then we will think of other strategies like mental practice, mirror therapy, which we'll see subsequently. So for this therapy to be helpful, some little bit of motor power, so that the person is able to, for example, extend the wrist as well as the finger extension have to be present minimally. And you constrain the normal limb. So for example, in this picture here, you can see this lady performing some functional activity, for example, holding to a glass of water, and the other limb is constrained. So what we are doing is we help to break the learned non-use. So that is what the constraint-induced movement therapy is about. It is to increase the repetition of the movement of the limb that is affected by constraining the non-involved limb, so that it can increase the cortical reorganization of the brain. Initially, when this therapy was started, it was a very aggressive regimen. For example, this constraint had to be worn for 90% of the day. So which means, like, for example, if you are awake for 18 hours, you have to wear it for, like, say 15-16 hours of the day. So that is going to be too much to ask for. So, and the therapy had to be performed, some activity exercise has to be performed for 6 hours of the day. So that was the traditional CIMT. Then they came up with what is known as modified CIMT by decreasing the intensity of the regimen. So here in the modified CIMT, you wear this constraint or wear this mitts or gloves, constrain the normal limb, and do that for only 6 hours of the day, and perform these activities. Like, it could be any activity to the person. For example, here you can see the person is pouring a glass of water into the other, or it could be spreading butter or jam or over the bread, or it could be laying down tasks like pins, etc. So such activities are performed for 3 hours a day. So in modified CMT, the intensity is decreased, but with the same outcome. Otherwise, there is no point. So with the little bit of decrease, the compliance is increased, the outcome is still the same. So to improve the compliance and to have the same outcome, we can use a modified CIMT technique. And modified CIMT technique, you have to wear the constrain the limb for 6 hours of the day and perform such activities, daily activities, or involving the upper limb for 3 hours of the day. Then with the advancements of technology, we have this virtual reality, which is incoming thing. We have virtual reality now easily available. This efficacy of these is not very clearly proven, but definitely it is a good adjunctive, a very good adjunctive, because one, it makes it interesting to the person, to the patient. It makes it very interesting to the patient. And second, the repetition is unlimited. That is, as long as you can, there is no necessary for a therapist to be physically present for the person to perform that activities. So that is a very important aspect, because the person can do this activity at home. And virtual reality, nowadays virtual reality goggles are available. Otherwise, they can even use the game boxes like PS4, Xbox, etc. are also being used in order to provide this virtual reality training and gaming. The efficacy is only adjunctive. It is not a standalone. It has to be adjunctive. And then when it comes to, as I told you before, so far the persons had some little bit of motor power preserved in the upper limb, or preserved, or rather it has recovered. So in such cases, you can do constraint-induced movement therapy, you can do virtual reality, you can do modified CMT, etc. But what if the power is zero? Is there anything? Well, there is things like mental practice. What is this mental practice? It all started with this piano experiment in 1995, wherein you see, this is the cortical representation of the finger movements. The cortical representation increases from day 1 to day 5. You see the cortical representation is gradually increasing in a person who is practicing the piano physically. Whereas in another group of persons, normal persons, they are mentally rehearsing the piano movement, and again there is a cortical representation of the finger movement is increased without actually moving, but imagining to move the fingers. So it is by mere imagination it has found that cortical improvement, cortical reorganization can be done. So it is definitely recommended as an adjunct which means supplementary to persons afflicted with stroke in whom there is no motor recovery. In the persons who are less imaginative, you can still fool the brain by doing what is known as mirror therapy. So this is for the less imaginative, those who are not able to mentally rehearse. You put a mirror across and you fool the brain into thinking that this is the other limb that is actually affected is actually normal. It is a reflection. So it is just like a visual imagery rather. And this can affect the mirror neurons, and again the efficacy is low evidence, but definitely very high evidence is seen in decreasing the pain in what is known as complex regional pain syndrome that is seen in stroke patients. Then there are functional electrical stimulation. Functional electrical stimulation, as we have seen in functional electrical stimulation, we saw one functional electrical stimulation for the lower limb, wherein it helped in dorsiflexion of the foot. So like that, we have functional electrical stimulation for the upper limb also. Functional electrical stimulation simply means application of electrical stimulation to the muscle groups to perform an activity. That is a function. So that is all. That is functional electrical stimulation. So this is a Bioness H200 system. Here, the stimulation of the forearm muscles occurs in such a way so that the person is able to grasp and eat an apple. So these are approved. They are found to be quite useful both in the acute, subacute and the chronic versions. The level of evidence is also quite good in such cases in persons in whom it is clearly indicated. So in persons, you have done everything. You have done the mirror practice, you have done mirror therapy, you have done mental practice, you have given CIMT, but then there is an end limit. As you have plateaued and there is no recovery that is seen, then is anything can still be done? Yes, something can be done for these persons to perform the day-to-day activities by simple modification of a grip handle. So the person whose grip is decreased, you do build up the handle. What is known as build-up handles can be given in order to either can be fitted into the brush, and the same handle can be fitted into the fork, and then he can use it to perform either brushing or eating, etc. Or if the grip is absolutely zero, for example, for this grip handle to function, some amount of grip has to be present, not complete but some, so that the grip aid can help in doing the activity. But it is completely absent, you can use what is known as a universal cuff. This is a universal cuff to which some items like spoon or even writing instruments also can be fitted. So such different self-help devices, depending upon the need, can be given for the persons in order to perform the day-to-day activities. So that so far we have seen all the sensory motor impairments and activities. We saw that it is important to take care of dysphagia, otherwise it can lead to malnutrition, it can lead to dehydration. In the early stage we give nasogastric tubes, and if for 2 to 3 weeks the nasogastric tube is given, then you do the assessment. The assessment can be bedside. Assessment can be done. If the swallowing is not come back, then you go for long-term intervention like gastrostomy tubes, percutaneous gastrostomy tubes. Then we looked at how to tackle cognitive impairment by doing some compensatory techniques, by keeping notes, by keeping reminders, by doing aerobic exercise. All this can improve the cognition. Then we saw what is hemispatial neglect, on how to deal with it. We saw the most common that is used is simple activation strategy, what is known as a limb activation strategy, or a visual activation strategy, that is by using eye patches. Then we also saw what is communication disorders. The most important is the use of alternative augmentative communication devices in order to establish a communication. Then we saw the role of Botox in order to decrease the spasticity. Then we saw the role of exercises and also not just exercises, there are also devices like balance masters and simple yoga or tai chi to improve the balance. Then we saw mobility. To improve the mobility, it is to improve mobility is you have to again he has to perform walking. If the patient is able to walk by himself, well, fine. If not, then you use a body weight supported walking. It could be body weight supported treadmill walking, or it could be robotic assisted when the person is not even able to move the limb. Then we use robot assisted mobility devices. Then we use assistive devices like canes and wheelchairs and improve the mobility in and around home. And finally, we looked at all the intervention strategies that was used for the upper extremity intervention strategy. So that covers the sensory motor impairment and activity intervention when it comes to rehabilitation. Then there are some interventions. I will briefly run through the prevention and medical management of comorbidities. There is a long list of things, but we'll go into more commonly is the skin breakdown or contractures, DVTs, bowel and bladder incontinence, shoulder pain, central pain, falls, seizures, depression, osteoporosis, and also a little bit about secondary stroke prevention. So skin breakdown is quite common in persons who are immobilized. That is, in persons like whether it is a paraplegic or a hemiplegic, skin breakdown is quite a big problem, especially in paraplegics because there is associated sensory impairment. It is less common in stroke patients wherein the sensory impairment does not occur. But still, the immobilization and sometimes added to that the cognitive impairment, and if there is bowel and bladder incontinence, then all these components, that is immobility, cognitive impairment, and bowel and bladder incontinence can lead to formation of such breakdown of the skin, commonly known as pressure ulcers. It is quite important to prevent the pressure ulcers by regularly assessing the sites where it can commonly occur. So the most commonly in a bedridden patient, you see that the ulcer commonly occurs at the sacral region, or it can occur in the heel because when you rest it. So it's quite routinely you assess this. And to prevent the pressure from building up, all you have to do is 2-hourly change of posture. And most important in prevention is to avoid friction, avoid pressure, avoid moisture. How do you avoid friction? Friction, how does it occur? When two surfaces go in opposite direction, there is friction. So in a person in hemiplegic who is bed bound, this friction can occur when you are transferring the patient from one bed to another bed, or from bed to the wheelchair, or from the wheelchair to the toilet. So during that period, the friction can occur and can lead to the pressure ulcer. So whenever you do such transfer activities, we have to be extra careful in order to avoid the intersurface movements, unneeded movements. And there is a prolonged pressure. Of course, the pressure ulcer is because there is prolonged pressure, and that can be prevented by doing a 2-hourly change of posture. So which means the patient is first supine, then goes to the side, then prone, then to the next side. So like that. Again, this is more important than the support surface. Support surface should not be hard, but it should not be too soft. But a firm support surface can suffice. Support surface, I mean the mattress. So a firm mattress is adequate enough, but 2-hourly change of posture has to be done in order to prevent the formation of ulcers. Now, in spite of, and take care of the moisture. By moisture here I mean incontinence, bowel and bladder incontinence. Take care of the bowel and bladder incontinence, because in such patients with incontinence, pressure ulcer can set in very quickly. If in spite of all the prevention strategies, the ulcer still occurs, then how do we deal with it? All that you need in most of the cases is normal saline and gauze, with which you can treat almost 90 to 95% of the pressure ulcers. If the ulcer is dirty, you first clean it. You clean it with what? You clean it with normal saline, and then you dress it with gauze. If it is deep, the ulcer is deep, again you clean it and then you fill it. You fill it with what? You fill it with gauze, with a soaked gauze. And if it is, the ulcer is open, you cover it. If it is dry, you moisten it, again with normal saline. And if it is wet, you absorb it with what? With gauze. So with normal saline gauze, you can almost manage innumerable stages of pressure ulcers, almost 90% of pressure ulcers. And next important is to prevent contractures. Again, at the beginning of the lecture, I had told you that intervention of rehab is as early as possible. As soon as the patient is medically stable, intervention starts. So even before the person is medically stable, in the ICU, contracture prevention plays a role. So this can be easily prevented by following some simple positioning techniques. So when it comes to shoulder, the simple abduction position, abduction and external rotation positioning. Keeping in this position, abduction and external rotation position, for 30 minutes every day can prevent shoulder contractures. As simple as that. And to prevent the contractures at the wrist and the hand. Now, contractures are quite common at the wrist and the fingers and at the ankle. So it is important again to position in what is known as a wrist roll. You keep rolled in a functional hand position. You give support in the form of a roll. And again at the ankle, to prevent plantar flexion contracture is quite common. So in order to prevent the flexion contracture, you position it properly at a 90-degree using a pillow, or you can use some devices. And in persons with established contracture, you can do standing in a tilt table, etc. for around 30 minutes, can also prevent ankle contractures. To assess the role, you can use some orthotic devices. I talked about one orthotic device before, that was the ankle foot orthosis, which was used for the lower limb. Similar to that, for the upper limb, we have the wrist hand orthosis. Again, this orthosis can be used in order to prevent the flexion contractures of the wrist or the small joints from occurring. And you can also use the AFOs. But more important than these devices is positioning, and to prevent the contractures, perform range of motion exercises also. Keep performing like 15 to 20 times, 3 times a day. They can also prevent the exercises. So to prevent contractures, one is positioning as appropriate. For example, for the shoulder, positioning can be used. For the ankle, positioning can be used. Then you do range of motion exercises, that is stretching exercises, or you can use splints in order to prevent the contractures. So in spite of such strategies, if the contractures still develop, then what can be done to these patients? What can be done? What is known as a serial casting. This is just nothing. For example, a person with a knee flexion contracture, we do a serial casting with plaster of Paris in the maximal stretchable position, and every 3 weeks we open the cast and we increase the angle, and then we recast again. So again, after the few more weeks, it is corrected. So it is a serial casting of the plaster of Paris over the joint that is affected, gradually progressively lengthening it. So there are sometimes, if the POP is quite difficult to be managed with, then you can use some orthotic devices with dial locks. So again, these knee orthotic devices with dial locks can also be set in order to progressively extend the knee joint. And if such interventions, that is interventions fail to improve the range of motion, or if you want to have quick benefit, then you can go in for surgical release. And a little bit of a DVT. DVT is quite common in stroke because of the presence of immobilization. So persons have, when they're immobile, have to be started on low molecular weight heparin. And in persons with stroke, that is hemorrhagic stroke, also low molecular weight heparin is started after the second or the third day, after it's made sure that there is no rebleed happening. So why I'm mentioning here is that this is quite a common complication which can be seen during the rehabilitation phase of the individual, and therefore you have to be aware that during this period that the person is under the cover of low molecular weight heparin. And also pneumatic compression, intermittent pneumatic compression devices can also be used as an adjunct, or in persons in whom such medications are contraindicated, then pneumatic compression can be quite useful. Then coming to incontinence, as I told previously with pressure ulcer also, incontinence is also sometimes present in a person with stroke. So it can lead to the problem. One common problem which I already told you is the skin breakdown, that is a pressure ulcer, which you already saw. Then another very afflicting problem is the social stigma, because the person who is having incontinence will smell, and therefore he'll have a social stigma, and for the caregiver it's going to be an extra burden a person with incontinence. So such patients have to be properly assessed. Simple techniques like intermittent catheterization can take care of the neurogenic bladder incontinence. Some medications for incontinence like antimuscarinic agents can be used in order to if there is some bladder hyperreflexia that is present. So I'm not going into the detail here, but what is important is to, in the rehab, remember that all these strategies are all quite important. So it is important to see whether the person has adequate bladder evacuation. So before discharge, always do get an ultrasound done to assess the post-void residue, and if the residue is significant, then you go for CIC. What is CIC? It is clean intermittent catheterization that has to be done. And sometimes pelvic floor muscles can also be strengthened in order to increase the bladder and neck muscles resistance, so that the overflow incontinence or the urge incontinence can be decreased in such patients. Another common problem is the hemiplegic shoulder pain, and this is almost present almost in 30 to 40% of persons with stroke, and quite common. It is important is to differentiate the hemiplegic shoulder pain from other causes of shoulder pain, like it could be bursitis or tendinitis, or it could be complex regional pain syndrome, or it could be a tear of the rotator cuff muscles. So those things are different, and hemiplegic shoulder pain is a different thing per se. It is a neurogenic mediated pain mechanism that causes hemiplegic shoulder pain. This is something different from the other cause of shoulder pain like bursitis, tendinitis, tears, etc. So how you can differentiate? By performing a simple musculoskeletal ultrasound, identify these persons, especially people with severe weakness of around the shoulder joint. They are more prone to develop shoulder pain, and hence in persons who have severe weakness along the shoulder joint, you have to follow proper positioning of the to prevent the subluxation of the shoulder. It could be like giving an arm board, it could be an arm trough on the wheelchair, or it could be a lap tray, or it could be a shoulder sling. This can be used when the person is seated, and this can be used when the person is standing and is ambulatory. A shoulder sling can be given. All this will help keeping the humerus inside the shoulder socket, the head of the humerus inside the shoulder socket, in order to prevent the onset of pain. And whether there is any medication, yes, there are different long list of medications. One common neuromodulating pain medications like amitriptyline, pregabalin, gabapentin have been found to be quite efficacious. And positioning is more important. Do some range of motion exercises, but not overhead pulley exercises. This overhead pulley exercises is completely contraindicated in a person with hemiplegic shoulder pain. Simple range of motion exercises can be done, but not these kind of exercises, pulley exercises. Medications can be started. Some specific interventions like botulinum toxin, steroid injection, nerve blocks are indicated depending upon the need of the patient. And in extremely rare cases, when there is severe spasticity leading to this shoulder pain, then surgical tenotomy may be indicated in some patients. Then you have to identify persons with central pain that is quite common after stroke in lesions of the thalamus or all along the spinothalamic trunk or thalamocortical tract. Such persons can be managed with amitriptyline 75 mg at bedtime. Most important is to rule out other causes of pain. Before you put in the reason as central pain, you rule out other causes of pain before starting such medications, because these medications have other cognitive side effects, so it's quite important that you treat them. Again, we coming to falls. Falls are quite common in the first 6 months, and it is important to do a fall risk assessment and improve the balance training, as I have seen before. This is simple standing and balance training, or on balance boards also can be used in order to improve the balance, or it could be instituting therapies like Tai Chi and yoga in order to improve the balance. And more importantly, do some home modifications, simple home modification. Now look at this picture, like cluttered furniture. This is an excellent recipe for disaster, for a person to with a stroke person to walk around, trip and fall. So make the environment clutter free, go minimalistic, keep it as simple as possible. Do not use rugs. Do have excellent lighting. Take away the rugs, take away unnecessary furnitures, and in the bathroom use some skid-free tiles. So simple strategies like that will help in preventing the falls. No seizure prophylaxis are indicated. Even though it may be prophylaxis is not indicated for seizures. Then take care of depression. Sometimes simple social support and peer counseling may suffice, and sometimes medications are indicated. Again, quite why it is important, because depression can have a negative impact on rehabilitation. So you must be aware of all the impediments to also rehabilitation, like depression, DVTs, or spasticity, pain, etc. And that is why I'm covering all these topics, so that you are aware. These topics have also been dealt with when you treat a person with stroke rehab. And depression is quite common. As high as 60% of stroke survivors have depression, but proper counseling and proper social support and using medications like simple fluoxetine 20 mg once a day in the morning can help in abating this, taking care of this depression. Take care of osteoporosis also in such patients. There is a more than 10% decrease in bone mineral density occurs in the first year itself. So what can be done about it? The only thing that can be done is any weight bearing activity. So you have to either walk or you have to use weight lifts. So only two things can help in building up the bone mass, and that is either you have to do walking or you do some strengthening using the dumbbells. And sometimes medications can also be done. I am not going into the medications. That depends if there is osteoporosis that is setting in or pre-existing one, then you continue with the medications that could be like bisphosphonates. You use zoledronate once a year, or ibandronate or alendronate once a week, depending upon the need of the patient. But physical activity, don't forget it. Weight bearing physical activity for the lower limb and for the upper limb in order to prevent the progression of osteoporosis. And last but not the least, when it comes to prevention of medical complication, is secondary stroke prevention. Make sure all the risk factors that can lead to another stroke, the second stroke, is all under control. Any blood pressure above 140/90 has to be adequately controlled with medications, preferably with diuretics, or sometimes with diuretics and ACE inhibitors are used in order to control. Look at the level of low density cholesterol. If it is more than 100 mg, bring it under control. And diabetics, target for treatment with HbA1c should be less than 6.5. Take care of the obesity by bone mineral body mass index. The body mass index, if it is more than 20 kg, then more than 20 kg, for every 1 kg there is going to be a few percentage of increase in risk for stroke. So improve the physical activity. So by physical activity I mean by brisk walking. It is not just walking slowly. Do some moderate or vigorous physical activity amounting to 150 hours in a week. So 150 hours in a week means 30 minutes over 5 days of a week. the person has to perform either a moderate or a vigorous activity. So moderate activity could be like brisk walking like walking at the pace of around let's say 100 steps per minute, or running, jogging, walking if it permits. So that has to be important to prevent secondary stroke. Good diet, salt restriction diet, Mediterranean type of diet has to be found to be quite useful in stroke survivors in order to prevent secondary stroke. Absolutely no smoking, and moderation of alcohol is also important for secondary stroke prevention. So herein we saw, after we saw the sensory motor impairments, we saw what are the medical complications, most commonly pressure ulcers, how to manage, more important, identify, prevention is better than cure, prevent the ulcers by preventing prolonged pressure, by doing too overly change of posture, or if the ulcer still occurs, simple normal saline and gauze is enough to take care of absolutely most of the pressure ulcers. You clean it, you keep it a little bit of moist, but you do not allow it to over dry, and take care of it so that the ulcer heals. Then you have to look into the prevention of deep vein thrombosis, even though a little bit rare entity, but it is a life-threatening condition, hence that has to be taken care of. Take care of bowel and bladder incontinence, shoulder pain, central pain, falls, seizures, depression, osteoporosis, and secondary stroke prevention. And finally, we'll look into also talk to the person about his sexual issues in order to go back to home, because sometimes the person who is afflicted will think that the other partner is not interested in him or her because of the appearance, because of the presence of any appearance that may be limiting him. So counseling can be useful in order to open up such issues. Counseling both the partners, that is the person affected with stroke survivor and his or her partner, talk to them about the issues and how to deal with such issues. And more importantly, we have to get back to work. So assessment, driving assessment, and return to work assessment have to be done by a vocational counselor and occupational therapist for driving assessment, etc., so that the person becomes gainfully employed. So to conclude, do a proper assessment, identify the proper areas, set goals, and then do a proper planning and intervention. The rehab intervention of two types: some to promote the recovery, that is the neurological recovery; some to promote the functional recovery, that is to treat compensatory strategies. Overall, the aim is to prevent complications in order to make the person perform functionally in a better manner and be gainful to the society. Thank you.
नहीं सर अब तो मुश्किल है